And there we go. We are now currently live. So hello and welcome to this Ask Me Anything live stream webinar with Dr. John Ligon. My name is Laura Turner, and I am the Executive Director for the Health Professional Student Association, which publishes the Student Doctor Network forums. And we're happy to welcome you to today's presentation. The vision of the Health Professional Student Association is that regardless of background or financial status, every student should have the same opportunity to attend a health professional school. We invite you to check out all the donor-supported resources that we have available at studentdoctor.net. We're glad you've chosen to join us for this Ask Me Anything session. We have a few housekeeping items before we get started. First, this live stream is being recorded, so you'll be able to go back and rewatch it or forward it to a friend who was unable to attend. Also, if you want to submit a question for this Ask Me Anything session, enter it in the comments section of YouTube or Facebook, wherever you're watching, and we'll pull it up on the screen for Dr. Ligon to answer. And now let's get going with a little bit of a background on Dr. Ligon. Dr. John Ligon is a pediatric oncologist with the National Cancer Institute. His focus is on immunotherapeutic approaches to pediatric cancer. Dr. Ligon completed his medical degree at Baylor College of Medicine. He completed a pediatric residency at the University of Texas Southwestern in Dallas and a fellowship in pediatric hematology oncology at Johns Hopkins University in Baltimore. And now I'm going to turn it over to Dr. Ligon for any opening thoughts before we dive into some questions. So let me just get the screen updated here, and there we go. Okay, so any opening thoughts that you'd like to begin with?
Hi, Laura. Thank you very much for inviting me. I'm very excited to do this. I think that SDN is a great resource, and I'm very happy to be able to offer any perspective that I have today, and hopefully we'll have some good discussions.
Great. Well, let's see if let's go ahead and we have some questions that we can go ahead and get started with. So let's start with the first one, and that is, when did you first decide that you wanted to become a physician, and why?
So I honestly can't remember like a specific time. It wasn't something that was common in my family. Neither one of my parents were in anything medical or even scientific. I honestly think that my pediatrician was just the coolest guy that I met growing up, and I thought that he was someone that I wanted to be like. So honestly, as early as I can remember, I thought that I wanted to be a doctor, and I kind of never really strayed from that and just kind of kept moving towards it. So I'm seeing a question in the comments. Are you still hearing me, Laura? I'll go ahead and answer the question that I see in the chat anyways. So the question in the chat is, what was my second choice for specialty if pediatric oncology didn't happen? So I think that's interesting, and honestly, I didn't know that I was going to do pediatric oncology until midway through my residency. I always was pretty sure that I wanted to do pediatrics just because I knew I preferred taking care of kids rather than adults. But went between a bunch of different subspecialties within pediatrics. I thought about maybe infectious disease or general pediatrics, but ultimately I decided on pediatric oncology because I kind of liked the complexity of the patients. I like that the patients that we take care of they present new and different challenges every day. And I also, unlike infectious disease, which was my second choice, that I get some continuity with my patients, and I really get to kind of learn who they are over time and have a long-standing relationship with them. And so that's one thing that I've found to be really rewarding about this specialty.
Great.
Nice. Do you want me to just keep kind of going down through the questions in the chat, or do you want to push some other one on the screen?
I'll push another one onto the screen for you. So sorry about that. My internet connection went down. So.
Oh, no problem. I hate when that happens.
Okay, so this one is from Ricky S. Thanks for joining us, and it's a question about what your typical workday looks like.
That's a good question. So, and I think that that is another thing that I actually really like about pediatric oncology, is that each of my days is very different. So I think pediatric oncology is kind of really unique in that it's very research focused, because we're all just very passionate about trying to improve the outcomes for our patients. And so most of us, in one way or another, are involved in some form of research. So for me, I actually spend a decent amount of my day doing research. During my fellowship, a lot of it was actually like at the bench doing, kind of experiments from 8 in the morning till 6 at night. Recently, the focus of my career has changed somewhat from basic science research to doing more translational research. So I spend a good amount of the day kind of writing future protocols, writing up papers from projects that we've been working on, and then kind of in between, throughout the day, if I'm on service, I'll go and see some of our patients who are referred for our clinical trials. And I kind of split that duty among the other physicians within our team. And then for a couple of weeks, like 4 weeks out of the year, I attend on the service and kind of take care of all the patients that are currently admitted at the clinical care center. So it's I find it's a really good mix. I really enjoy seeing the patients and the patient population that we take care of, and I also enjoy that where I am, and right now I have a lot of time where I can also kind of think about future and upcoming projects. That I guess there's no typical work day, but I like that it's every day is a little different.
Great, thanks. Let's go ahead and jump down to the next question, which is from Jennifer Kurzman. Thank you, Jennifer. What is most challenging about oncology?
That's a really good question. So, I mean, I think all of us who are in pediatric oncology, we all kind of have that typical reaction from people when we tell them that we're pediatric oncologists. I think they kind of classically say, "Oh, that must be so hard." And the good thing about pediatric oncology is that actually most of our patients survive their cancer. Up to about 70 to 80% of patients are ultimately cured of their cancer. But the patients that don't survive, obviously, is the hardest part. And I think that those final days, where you know that there's nothing that you can do to change the ultimate outcome, but you still are there with the patient and their family as things are getting progressively worse. That's definitely it's an honor, but it's very difficult to do. So I think without question that those patients that we're not able to save, spending those last days with the patients can be very difficult. So I think that's definitely my answer.
On the flip side, we have a question from Liara asking what are rewarding aspects of being a pediatric oncologist.
And
go ahead.
Yeah, absolutely. So it's really cool seeing the patient come in on their last day of chemo, getting to ring the bell and say that they've finished all their chemo, that they're cured from their disease, that they're able to kind of enter survivorship. And so that's there's nothing that beats that feeling. And then a lot of times these patients have to keep coming back every few months off of therapy to get scans and make sure that the cancer doesn't come back. So you can kind of see them as they continue to go back to school and go on vacations. Occasionally, we'll get an email from our adolescents and young adults who, they say that they, are getting married and, seeing that they went from being so incredibly sick to, getting back to living a normal life is, really rewarding. There's nothing that beats that. And I will say also, but nothing beats having a patient say that they're getting married. But I really do love the discovery aspect, and the fact that it really is a part of our daily work to always be starting new studies, writing new papers, and trying to continue to move the bar forward as a part of our daily practice. So I really like, for me, the active involvement in research is a major plus to my specialty.
What was your rotation and residency period like? Was the match period difficult?
That is an interesting question. So, I think for my clinical rotations during med school, I actually was one of those people that liked basically everything that I tried. But while I at least entertained all of the other specialties, when I got to my pediatrics rotation, it basically confirmed what I always thought was that pediatrics was definitely right for me. And I think it's mostly that I just couldn't take myself seriously enough to do anything other than pediatrics. So I enjoyed learning about all of the different specialties. It wasn't bad, but pediatrics was clearly my favorite. In terms of residency, it had its highs and lows. I would say I really actually enjoyed my residency for the most part, particularly once I made it out of the first year or the intern year, because once you get to the point where you're a second or third year resident and you kind of are the senior resident on the team, and you can kind of start to gain a little bit more of a bird's eye view in leading the team. I thought it was actually really kind of fun to supervise other interns and kind of help them along as I did the year before, and also taking care of medical students and trying to teach them on the wards. So while it was certainly busy and difficult, it was also, I really enjoyed the work that I was doing. I liked everything that I was learning. So overall, I really liked my residency. In terms of the match, I will say that it was somewhat difficult. I wound up, when I was applying for my residency, I can say this in retrospect, and I have only good things to say about my program, but it wasn't it wasn't at the top of my match list. But in retrospect, it wound up being exactly where I needed to go for my residency. I met some incredible mentors at UT Southwestern who helped me decide to go into pediatric oncology. I met my wife in Dallas. I was absolutely exactly where I was supposed to be.
Okay, our next question is about how do you match into a good hem-onc program?
Okay, so that's a good question. And I will say that I only really have my perspective as a pediatric oncologist, but I think my my advice probably is the same regardless. And I think I think that both pediatric and adult hem-onc are pretty research-focused specialties, particularly in fellowship. So, I think that any kind of research experience that you can get during residency, I think will look good on your application. And I know it's tough to kind of go and check a box during residency when you're already so busy, but being able to show that you're able to balance your workload and really see a project through from kind of conception all the way through to publication shows that you have a level of commitment and that you can really be part of that academic process. So just finding the time management to be able to be involved in really any kind of research project, even a small case series, I think can be seen favorably.
Okay, and then this is about doing both research and treating patients.
Yeah, this is a really good question, and I think something that I didn't really realize until honestly I was even in fellowship. I think that there are certainly some specialties that are a little bit more research focused, and that includes the one that I'm in. And there are some specialties where I think there are some competitive specialties where it's kind of a requirement that you do some research. And then there are other specialties like where pediatrics, where if you want to do research, there's no, there's kind of like no limit to the amount of research that you can do because it's not something that's like required or expected of every applicant. So at least in my case, it was something that just in medical school, I reached out to some of my mentors and said, I have, time to take a research elective. I think I would like to just be involved in clinical research. And kind of get my feet wet. And I found that I really enjoyed it. And I think that in a lot of ways, I've kind of been steered towards a specialty that was more research focused. So if you want to be involved in research, I think taking the time just to reach out to mentors during medical school, and having them give you guidance on how to get involved in projects early on. It certainly doesn't. It's not going to hurt you, and you may find that you really enjoy it, like I did.
And this one, ongoing research in a different but more research-focused program.
That's a good question. It's a little hard for me to answer, to be honest, because I only know my own experience, which was at a pretty research-focused program. I would imagine that it's possible, but potentially difficult, and maybe kind of dependent on the connections that your program director may have with other nearby programs, if that makes sense. Because to expound on that a little bit, I think that if you're going to reach out to kind of like cold email a program director somewhere else, they have no idea who you are, you may not get a response back. But if your program director reaches out on your behalf, or kind of knows some other people at nearby programs who have been receptive to their residents being involved in research, they may be able to steer you a little bit better than if you were kind of reaching out blindly. And I think that gets a little bit to just an overarching point that I'd like to make, is that I think it's important early on and kind of at every point along the way to identify who your mentors are. So that can be someone who is formally assigned to you in medical school, or it can be someone that you meet along the way and who just kind of informally starts giving you career advice. I think that having these mentors who can give you advice on your career, and I think equally importantly, introduce you to other people who can help move your career forward, is really important.
Schedule. What does your schedule look like?
Yeah, so it really kind of depends from one week to another. So right now, the team that I'm on has 3 attendings on it. So roughly 1 out of every 3 weeks, I'm responsible for the care of the patients who are referred to for our clinical trials. So 1 week out of 3, I'm kind of communicating with the inpatient team about our patients and kind of giving our recommendations from a protocol standpoint. And the other 2 weeks tend to be more kind of academic work, focused on like writing papers, meetings, journal clubs, things like that. Then 4 weeks out of the year, I'm on service, and so for those weeks I tend to be at the clinical care center from like 8 till 5 or 6, rounding with the fellows and the rest of the team on any of the patients who are currently admitted, and taking care of acutely sick outpatients and things like that.
We have another question from Ricky about what do you recommend for someone who is entering medical school interested in pediatric oncology? or just any general medical school advice?
Yeah, so I think that as you're entering med school is a great time to, kind of just keep your options open. I think, go into every clinical rotation with an open mind. And I think in general for medical school, I would get back to identifying a mentor early on in the fields that you think that you might be interested in. And if they are fields that, kind of require research, or if that's just something that you want to have be part of your medical school experience, kind of have them recommend who you should reach out to get involved in a project. Because I think, again, it having these mentors reach out on your behalf can be much more helpful than you cold emailing a bunch of people without an introduction. In terms of being interested in pediatric oncology in med school, honestly, you don't have to do anything special in med school because in general, none of the pediatric subspecialties are that competitive to get into. But if you think you might be interested in pediatrics, then having a mentor in pediatrics kind of point you in the direction of the the pediatric hem-onc fellowship director, and see if they know someone who may be looking for a student over the summer to help with a clinical project or something like that. I think that that's definitely something that you could do to try to get involved in a project. And I will say that pediatric oncology is a pretty research-oriented field. So at some point, either in med school or in residency, you should probably gain some sort of experience in clinical research to see if that really is something that you want to have be part of your career.
Great, thank you. We don't have any more questions, or we'll keep it open for some more questions from the audience. We do have a few more of our 20 questions that we ask physicians, so we'll hop over to that. If you do have more questions, please feel free to leave those in the comments of either Facebook or YouTube, wherever you're watching, and we can get those in front of Dr. Ligon. So we'll go ahead and jump over to another 20 questions. And that one is, how and why did you choose the medical school you attended?
How and why? So I guess for me, it was a little bit different because we were, and I apologize, I'm just getting a message about like patients at work. So I was responding to that quickly. So for me, it was a little bit different. I was from Texas, so I was, so I was pretty sure that I wanted to stay within Texas because, to be honest, the cost is so much lower for Texas residents, and I just had a really good feeling from Baylor. Obviously, it's a great school, and I really felt like I fit in really well there. So it was a pretty easy decision for me. I was involved in some undergraduate research, and so the fact that Baylor really had a lot of opportunities for being involved in research as a med student was something that appealed to me. So once I got accepted there, I have to be honest and say that I didn't strongly consider, my other options that carefully.
Okay, we've got a few more questions that have come in. So I've got another one here from Ricky. Thank you for your question, Ricky. And they're following up with a question about clinical research versus bench research.
Yes, absolutely. So I'm trying to, okay. So I see this is a follow-up from earlier. So absolutely, yes. The research that you do in med school can certainly be clinical research rather than bench research. And in fact, I think unless you're willing to kind of take a whole research year, I think it's very difficult to be productive in bench research during medical school. Like we just managed to get my main fellowship paper accepted to a journal a couple of months ago, and this is after I had been in fellowship for over 4 years, being in a lab for over 3 of those years. So, and completely focused on doing that work. So I think that, thinking that you're going to be able to squeeze in a couple of hours of bench research and have it be, something that is meaningful during, first and second year of medical school, I think is very difficult. On the other hand, there is often no shortage of small case series or retrospective chart reviews that someone within a department has kind of been kicking around in the back of their head, that they just need someone to kind of go in and do the actual work of reviewing all of the charts. And that's definitely something that you can find if you know who to ask. And it's I think if you are able to kind of put in that work, it can definitely be something that you can manage to do as a medical student.
Got another one here from Chevius. Are you ever able to completely unplug from work, and how much does work intrude on your home life?
That's a really good question as well. And I think it's actually gotten much worse in the era of COVID, honestly, because now I've been doing a lot more remote work. And so now, after I put my kids to bed, my computer, which I've been working at all day, is still right there. And I know that there's like a paper that I haven't finished writing, or emails that I need to follow up on. And so it can be difficult to kind of unplug, because there's always more that you could do. And so I think that I have definitely found over the years that you just have to decide, that I'm only going to, work X number of evenings a week. And then the other nights, I'm going to sit on the couch, I'm going to watch some garbage TV, and I'm going to, kind of just rest. And in fact, this last weekend, my wife and I, we made a point of just renting an Airbnb like 30 minutes away from home and going and kind of disconnecting from the world. And it was great and very much needed. And sometimes you just have to make an active decision to kind of separate yourself from work. Because I love my job. I am very, very happy to do what I do. But you can definitely run yourself ragged and burn out if you're not careful.
Thank you. And now we have another question from Prashil. about what dragged you towards oncology, because you said that you were interested from the beginning, really, in pediatrics. What drew you to the oncology aspect of it?
Yeah, so I honestly, I keep coming back to mentors, but at least for me, that really has been kind of an overarching part of my journey, was that I tried to remain as open as possible. And I found people who were excited about what they were doing, and I just kind of decided to follow in their footsteps. So, you know, that's kind of how it worked for me during my residency. Was the people who were doing pediatric hem-onc were very excited to do what they were doing, and they were people that I could kind of see myself emulating. So that's kind of part of what drew me in that direction. Along with the fact that I generally feel like I like complexity in my patients. So I like having to kind of balance a number of different active issues, and, you know, kind of, I like how it keeps me on my toes, for the lack of a better word. And I do like also how, you know, it really does keep me involved in research. So for all of those reasons, you know, that ultimately is what pulled me towards oncology. But I will say that it was not an easy decision at the time. I decided that I was going to do peds hem-onc like literally a month before the application opened during my residency. So, in retrospect, it seems like so obvious, but it wasn't obvious at the time.
Okay, and now we have another question from Jennifer. Thank you for your question about breaking bad news to patients' families.
You never get used to it. I think that ultimately you kind of learn that you just kind of have to be straightforward about it, because if you go into the room and you're kind of talking around the news that you all know that you're supposed to be talking about, they kind of learn that it's going to be bad news, and at some point you just need to kind of give them the bad news and, you know, let them hear it, and then you can, honestly, you need to give them some time to kind of react and process it, and then you can move towards trying to talk about what the next steps are. But I think, and everyone as a first year fellow makes this mistake. Like, we all try to like rush into like, here's the bad news and here's what we're going to do to try to fix it. But you really need to give patients and their families, you know, some time to absorb the bad news, and give them their time and space. And then what you're going to do about it will come, but you can't rush them to get to that point, if that makes sense.
Yeah, that makes sense. I'm going to jump back over here to another question from Christelle about, you know, again, and a follow-up to kind of Jennifer's question about mental burnouts after multiple poor prognoses.
It's a really good question, and it's something that we struggle with. I think it's necessary to always come together as a team afterwards and debrief after a bad event. So we had one of our patients die. We expected them to die, but I think it happened more quickly than we necessarily expected to happen. That happened recently. And so in the days afterwards, we had a couple of meetings with everybody who was involved in the care of this patient, and just we all kind of talked through our experience with the patients, trying to decide, is there anything that we could have done differently, and to make this outcome less terrible, and ultimately most of these discussions wind up coming to the conclusion that yes, we did everything that we could have done, and this was about as good of an ending as you could have had for this patient. But I think it is important to kind of have those discussions with everybody else on the team, and kind of all acknowledge the feelings that you're having. And I will just, be very honest and say that, particularly over this last year, where I think there is a lot more isolation and a lot more difficulty that just comes with COVID. I found that it was helpful to talk with a mental health professional myself. And a lot of my peers have told me that they have done the same thing. And so I think that simply recognizing the symptoms of burnout and not being afraid to reach out for help is very important.
Thank you. We've got a question here from Lakshman about how many patients do you typically interact with while you're working at the clinic?
So that's a good question. And I guess I should probably also have made clear that I think at the NCI, it's definitely an unusual situation, because everyone who comes to see us have been referred for an early phase clinical trial. So these are all patients who are multiply relapsed and are looking for an experimental therapy. I would say that our particular team probably has somewhere between like 4 and 8 patients who are referred here on campus at any given time. If I'm on service, we probably have about that many as well who are admitted at any given time, between 4 and 8. So it's really pretty small services, but very complex patients, given that they're multiply relapsed and they're all on experimental therapies. During my fellowship, it was a little bit more of a kind of a typical clinic and a service. So I would say that the inpatient census was usually somewhere between 10 and 20 inpatients, and we would probably, like if I was in clinic, I would see somewhere between 5 and 7 patients on any given half day of clinic.
Great, thank you. We have a few more minutes here, so if there's additional questions that folks want to drop in, please feel free to do that, again, on the comment section of either Facebook or YouTube. We've got a couple more questions here from our 20 questions. A lot of these we've already kind of touched on, so I'll try and find one that we haven't detailed. So how about this one? How many hours a week do you work? How much do you get? How much vacation do you get?
These are all great questions. So, and it just depends how you add up all of the hours, to be honest. I would guess that I'm probably working somewhere in the like 55 to 60-ish number of hours a week, if you're including like all of the hours that I'm like writing papers and stuff. As I'm getting in, a little bit further into my 30s, I'm fine, and I have kids, I am finding that I really need somewhere between 7 and 8 hours of sleep a night. I can get by with 6 hours of sleep for maybe a night or two, but I really can't do any less than that. And then the question about the weeks of vacation is a little difficult. I think that I technically have 4 weeks of vacation during any given year. But to be honest, I've wound up using them a lot recently on things like paternity leave because I've had kids. So it's almost difficult for me to keep track of that. I will say that I am in a very supportive environment that kind of allows us to be flexible in how we use our vacations. So sometimes I find that it's easier or more beneficial to just like take a Friday off and have a long weekend than take giant blocks of time off.
Great, thanks. We have one more question here from Jennifer about how do you decide to try a treatment that hasn't been officially approved by the FDA?
So that is an excellent question, and it's very difficult, especially because all of our cancers are rare. Basically, unless like it's acute lymphoblastic leukemia or some of like the most common cancers, you really don't have enough patients to do like phase 3 clinical trials, which is usually what is necessary to get an FDA indication. That said, and I will say, and if you are thinking about patients with relapsed and refractory disease who've already failed 1 or more lines of therapy, then a lot of times you're kind of really kind of in the weeds and trying to do your best. That's not to say that we don't have some idea of what makes the most sense. We have a number of 3rd and 4th line options that do have evidence based on smaller clinical trials, and a lot of times we are able to get them approved. If you are able to kind of go to the company and say, look at this study, this is why we think that this would be the therapy that makes the most sense for this particular patient based on the toxicity profile and maybe the specific mutations that are present in their cancer. But honestly, a lot of times it does require us actually going and speaking with the insurance company and getting prior authorization for these kinds of therapies.
Okay, we've got one more here from Chevius with the new picture. What do you wish people knew about your field, and what do you think is the biggest misconception about your field?
That's a good question. I mean, I touched on it a little bit earlier, and I would say that the biggest misconception is that it's just an incredibly sad field. And like I said, most of the time, our patients are cured of their disease. I guess maybe not, unfortunately, the patients who are enrolled in early phase clinical trials because they're relapsed and refractory. But 70 to 80% of children with cancer will ultimately be cured of their disease. So it actually is a very, kind of rewarding part of the field to be involved in that kind of journey for so many patients. I will say, so I would say that that's the biggest misconception about our field. It's not horribly sad all of the time. I would say what I wish people knew about the field is a little bit of just how academic it is. And that is definitely a plus for me now, but I don't think that I necessarily understood that until I was really in the application process for it. And what I mean by that is that, again, pediatric cancer is rare. And so in general, pediatric oncology is a specialty that kind of exists within tertiary care centers for the most part. And so if you are going to go into this field, you kind of really have to have that, passion to be involved in, research in some capacity, or being involved in like medical education, or, doing some sort of academic productivity, because that is likely to be a part of your career. Again, this is a positive for me, but I don't know that I really understood, that was kind of the reality for a lot of pediatric oncologists.
Great, thank you. Well, we're coming up here on the end of our hour. It's been quite a busy set of questions here. I'm going to go ahead and put one more question to you. In your position now, knowing what you do, what would you say to yourself back when you started your medical career?
I think, honestly, I would kind of give myself the same advice that I gave a little earlier, and it's just really follow the advice of your mentors. Always be open to new experiences. Don't go in with any preconceived notions, because I think if I had kind of stuck with my preconceived notion that I was going to be a general pediatrician, or that I was going to be a pediatric infectious disease doctor after that, I might not have developed the mentorships that I did in medical school, and I wouldn't have arrived at where I am now. So I think a lot of people enter medical school and then residency with ideas of where they want their career to go, but just be willing to sit down, have a conversation with anybody, and stay in touch with them, and be willing to change your career trajectory when new opportunities arise.
Great, thank you. We got one more question here. Do you want to go ahead and take that one?
Sure, absolutely.
Okay, so one more question here from Jennifer about how long a patient has to be cancer-free in order to be considered cured?
That's a good question, and I think that it depends on how you look at it differently. Patients are definitely very excited when they finish their last kind of cycle of planned chemo. I guess I would consider that an easy benchmark. There's always going to be some number of patients who will relapse further down the line, but in general, for different kinds of cancers, it may be once you hit the 1 year mark after finishing chemo, you're much less likely to relapse, or if you make it to the 5 year mark, you'll be much less likely to relapse. It really is a little different for each kind of cancer, where kind of like that survival curve flattens out, and you become less likely to relapse later. So I think it's a little easier to just say that, when you're done with chemo, you're a survivor. And obviously some percentage of those patients will eventually relapse later, but That's probably the easiest benchmark to use.
Great, thank you. Well, I think we're just about out of time here, so I want to go ahead and say a big thank you to Dr. Ligon for taking his time in the evening, and obviously, you know, he's got lots of stuff going on, so we really appreciate him taking the time to do this Ask Me Anything session with us. And I want to thank everybody who attended and asked questions. I want to remind you that if you joined us late, it will be available for viewing on YouTube afterwards, so you can go back and view it. And lastly, I want to remind you that we have lots of donor-supported tools and resources available on studentdoctor.net to help you with your journey on becoming a healthcare professional, and we invite you to check them out. Again, thank you, Dr. Ligon. I really appreciate it. Any final words to close up?
No, just thank you everyone for coming and joining. I really appreciate the questions, and yeah, thank you so much for making this a great hour.
Great, thank you. And we'll be announcing our next webinar soon, so you can subscribe to our YouTube channel and there'll be an announcement there, or you know, just keep an eye on the studentdoctor.net forums. There'll be an announcement there as well. So thanks again for coming and have a pleasant evening.
Bye.